Okay, good afternoon, everybody. Thank you so much for joining us. My name is Katie Green. I'm the Director of Public Health here at the National Academy for State Health Policy. I'm joined by my colleagues Megan D'Alessandro and Maddie Harbour, as well as some really fantastic speakers to discuss an important and really all too forgotten topic, which is the importance of oral health, and specifically why oral health is an essential part of overall health and the role that access to high quality dental services can play in preventing and addressing many of the chronic diseases that are really some of the largest contributors to morbidity, mortality, and healthcare costs in the United States. So in today's webinar, you'll hear more about really the mounting evidence that points to a bidirectional relationship between oral health and chronic disease, including dementia, cardiovascular disease, diabetes, and HIV, just to name a few. And you'll also hear from a number of states that are really leading the way in implementing strategies to integrate siloed medical and dental systems, improve access to preventive care and dental services, and support coordinated care to improve both oral and physical health. Next slide. Just real quick for some of you that might not be as familiar with NASHB, NASHB is a nonprofit, nonpartisan state health policy organization dedicated to improving the health of people in all states and all communities. We work to exchange strategies and solutions to health challenges across the full spectrum of policymakers and implementers, both in the executive and legislative branches. And this webinar and our work has been supported by a longtime partnership with the CareQuest Institute to support state dental directors and other oral health leaders with implementing strategies to improve oral health and reduce disparities in access to high quality dental care. As part of this work, we maintain an ongoing state leaders work group and listserv that supports exchange of resources and best practices. And we really just provide a forum for state policymakers to work through ongoing challenges in the oral health space, including some of the priorities related to integration and whole person health that we'll talk about today. Next slide. As I mentioned, we've got some great presentations from state dental leaders in both the Medicaid and public health space. We're thrilled to be joined by Dr. Zach Hairston and Justin Gist with the Virginia Department of Medicaid Services, Dr. Donald Pulaski from the Connecticut Department of Social Services, and Mary Kenyon Jones with the South Carolina Oral Action Health Network. Following our presentations, we'll have lots of time for moderated Q&A, so please keep those questions coming in the chat, and we'll get to as many as we can in the discussion. Next slide. Just for some quick housekeeping, we're recording this webinar, which will be available on NASHB's website. We encourage you to share it with anybody that might not have been able to make it today, but for everybody that's here, please do go ahead and feel free to submit questions for panelists in the Q&A throughout the webinar. We'll move right through the presentations, but we'll get to as many of them as we can during the discussion. And after the webinar, we'll be linking to a short post-webinar survey. Please do fill it out. It helps us inform and think about how future content and things that we can learn on this topic. And lastly, please stay in touch. Please reach out to us directly at oralhealth@nashb.gov if you're a state official looking to be connected to our work group or listserv. We'd love to hear from you. So without further ado, I'd love to hand it over to our friends in Virginia to kick off and tell us about how they're making the connection between oral health and chronic disease. Dr. Hairston and Justin, over to you.
Good afternoon. Excuse me, Justin, you're going to go first, or you want me to go first?
Oh, yeah, Dr. Hairston, please.
Oh, okay. Good afternoon, everyone from Virginia. I'm going to speak from a medical dental perspective, and I'm going to speak specifically with two of our programs, our Pregnant Women Benefit Program and our Adult Dental Benefit Program. Next slide, please. Our existing adult dental program had its genesis in pregnant women benefits. We brought on the Pregnant Women Program in 2015 as the Healthy Babies Initiative and help recognize why low birth weight babies may be occurring. Next slide. This is what we are able to say. Our role as dentists is to make sure we can promote healthy lifestyles during pregnancy. And what we've discovered is a lifetime habit of care for teeth and subsequent good oral health for the child tends to go hand in hand. If the mom is a good participant in dental care, then it's expected that the child will be a good participant in dental care. There is vertical transmission of carriers bacteria across the placenta. And what is highlighted in blue here is most important. A woman's lack of receiving routine dental care when not pregnant was the most significant predictor of lack of receiving care during pregnancy. Next slide, please. Periodontal disease is one of the causative factors for low birth weight babies. When there was a low incidence of periodontal situations, birth weight babies were 2.5%. In periodontally healthy women, it increased to 8.6% in women with periodontal disease. And if there was severe periodontal disease, there was a greater than 75 percentile of a greater risk for delivery of a low birth weight baby. And I'll ask that you stick a pin in just this business of periodontal disease and low birth weight babies. Next slide. Preeclampsia is specific to pregnancy. It causes high blood pressure. It causes protein in the urine. It arises about 20 weeks into the pregnancy, and it can have undesirable outcomes for the mom and the baby. Next slide. I don't have a slide that focuses on other subgroups, and I apologize for that. But I do believe it important to share this slide, however. Black women are 3 times more likely to die from a pregnancy-related cause than white women. And I felt this important to show when we have something as precious as the newborn in the mom, this statistic really got my attention here. Next slide. From 2015 to 2020, we used the adult dental benefit to help the pregnant women benefit to help to set the stage for how we were going to fashion the adult dental benefit. And we were charged to look at the codes that we had for pregnant women and use that as a guide for determining our adult dental benefit model. Now, there was exceptions, especially when it came to prosthetics and removables. But we were receiving, just about the time we were ramping up the adult dental benefit, we were receiving feeds, multiple feeds on impacts beyond the mouth. And many of us have heard oral health equals overall health. And there was a sea change occurring nationally, even in many of the seminars that Justin and I were attending. And the whole health sphere was picking up the same associated literature of this medical dental relationship present. For all the time we as dentists have known that there's a medical dental relationship, it was receiving renewed attention. And we cut our teeth on this slide here in our many presentations. The print is somewhat small, and I wanted to give a nod to this slide because we used it so often, but we then graduated to the next slide, if you will. Everything that was on the former slide, we see on this slide. And we can see that respiratory infections have their genesis in the mouth by way of pneumonia sometimes. Severe osteopenia is associated with gum disease. We talked about low birth weight babies. Stroke has a relationship to adult periodontitis, heart disease, adult periodontitis, and uncontrolled diabetes has a chronic relationship to periodontitis. I'm going to ask that you stick a second pin in this slide as we move forward. We got 2 pins now. Next slide. I was privileged to hear a gastroenterologist speak just this weekend. And his big takeaway is most all we encounter that's detrimental to our health is due to lifestyle issues. He enumerated heart disease and cancer as number 1 and 2, and he attributed these to lifestyle issues. And when he spoke of lifestyle issues, he talked about eating, what we eat, tobacco, and alcohol. Next slide, please. It's interesting that many of the social determinants of health that we see in many of our Medicaid members have to do with those same 3 lifestyle issues that was brought up. Cigarette smoking, what the gastroenterologist mentioned, what the gastro person mentioned was that tobacco in all its forms, not just cigarette smoking. So that means snuff, and that means chewing tobacco also. Alcohol is what it is. And if we go to the far right, poor nutrition is the 3rd risk factor he mentioned attributed to lifestyle. So as I said, these social determinants of health tend to present themselves quite a bit in our Medicaid population. Next slide. This picture, I believe, is powerful. And as you can see, the tooth is also in the shape of a heart. And we see the gingival tissue surrounding it. When I was speaking earlier of pregnant women benefits and adult benefits, and I said to stick a pin in, is because bacteria associated with periodontal disease in the mouth has been found in heart tissue. So that means that bacteria has traveled from the mouth to the area by way of the bloodstream to the area of the heart. And if we think about the lifestyle factors again, eating, smoking, and alcohol, low birth weight babies, respiratory infections, osteopenia, heart disease, diabetes, everything that I mentioned that has its associated with periodontal disease, all have one common characteristic. They all have the same mechanism of entry to our body, and that's the oral cavity. Next slide, please. We developed our adult donor benefit and the pregnant women benefit on if we have our seniors going into the office, what's the simplest thing that can be done? And the simplest procedure that can be done in most dental offices is hygiene, the hygiene program. And as a part of making sure that we address the periodontal situation that's occurring in low birth weight babies and adult dental care, is we established up to 3 cleanings a year for our adult and pregnant women program. And the reason we wanted to do simple is because there are oftentimes, I know this from practicing for at least 40 years, seniors want simple. They want procedures that they want to go to sleep at night. If a tooth bothers them, they want it taken out. They're not necessarily interested in many major procedures. And with hygiene being 3 times a year, we felt like this is not an every 6-month thing. 3 times a year could be customized to each one of the members that we are going to see for 3 times within that 12-month period. And the reason we say that is some folk that haven't been to the dentist in an extended period of time, they can get tired quicker. And if they got such a large buildup, then it can take more than one appointment. But if we as hygienists try to do it all in one appointment, then it's going to tire them out. And the bullet at the bottom, the foundation of everything dentists do, from restorations, dentures, partials, will have greater function and outcome if we can consistently get seniors to keep their hygiene appointments. If we can go to the next slide, please. This is somewhat repetitive to the slide that was before, but I wanted to highlight again, the reason we believe our program sets apart is because up to 3 cleanings per year based upon customization by what the patient calls for. And with that, I'll hand it over to my colleague, Mr. Justin Jess.
All right. Good afternoon. Thank you all so much for joining this afternoon. And before I begin, I want to extend my sincerest appreciation to our partners at NASP for the invitation to discuss Virginia's response to the link between oral health and chronic disease. Dr. Harrison and I are certainly no strangers to NASP in the webinar series. But for those of you who we haven't met yet, and just to level set, I am the dental program manager for Virginia's Department of Medical Assistance Services. And in my role as program manager, I have both the charge and the absolute privilege of managing Virginia's Medicaid dental program. And one of our primary aims for today's discussion is just to provide a glimpse of how Virginia addresses the role that oral health plays on chronic disease. Dr. Harrison mentioned this earlier, and many of you know that there's really been a collective push within the health space to educate members, providers, stakeholders on the importance of oral health on overall health. And really one of the reasons that I'm so passionate about oral health and the work that we do is because of 12-year-old Diamante Driver. So the world was really able to see in real time the effect that oral health has on overall health. And if you haven't read the story on Diamante Driver, I highly recommend you do so. It's really a life-changing story on how delayed access to oral health can lead to catastrophic life-changing events. And Dr. Harrison really set the stage by detailing how the comprehensiveness of Virginia's dental benefits really support the growing body of evidence that good oral health is a prerequisite of good overall health. So I just want to spend the last few minutes of our allotted time today discussing a program that we've implemented in Virginia that connects members with intellectual disabilities, chronic disease, and other special healthcare needs to our oral healthcare providers. Next slide, please. All right, so in 2023, Virginia introduced the Case Management and Care Coordination Program. And this program was created to address access to care for our members with intellectual and or developmental disabilities and members with special healthcare needs. So we know that an enormous barrier within the IDD population and our members and our population of members with cancer, with heart failure, and other chronic diseases is finding a provider who can serve their needs in a timely fashion. So when looking at the Case Management and Care Coordination Program, the first level priority is access. So connecting individuals with healthcare barriers to oral healthcare providers. And a byproduct of the program allows for collaboration between our dental benefits administrator, DentaQuest, and the members MCO, and that further strengthens the medical dental integration and collaboration. DentaQuest originally launched this program in 2018 in Florida, and I have some quantitative information about the program here. And just as an FYI on the graduation rate, what this graduation rate means is that the member has completed a case management process that involved a plan of care that was designed to really bridge any gaps in their dental care and oral health. So once the member has an ongoing source of care, so that could be a dental home, it could be an office or facility that the member can go to for specialty care. Once that member has a clear path of what will be done to improve their oral health care, and once all the goals are met, the member has graduated. So really the marker for graduation would be, is this a member or caregiver? Is the member or caregiver, are they in a place where they can manage their oral health care moving forward? So that's really, if you wanted to put a marker on what does graduation look like, that would be the marker, right? So does this member, can this caregiver, are they comfortable with where they are with their oral health care moving forward? Next slide, please. All right, so the case management program is broken down into 3 main steps. So the first step, identify and assess. So members who need case management or care coordination, they're identified in a few different ways. So it can be through the new member welcome call that DentaQuest conducts for all of our new Cardinal Care Smiles members. So during those welcome calls, if a member or if a caregiver indicates that the member has a special health care need or a chronic health condition, for example, a member is disabled or the member has renal failure or heart failure, or any other health barrier to receiving oral health care, the member is placed in the case management program. Another way is identification through direct referral sources. So this is really one of the primary ways, right? So referrals from the member's managed care organization, referrals from other medical care providers, primary care physicians, cardiologists. mental health providers. These are all potential referral sources for the members. The next step is assisting. So once the member has been identified or referred, a one-on-one outreach is done by a dental care coordinator or case manager at DentalQuest. So at that point, the person-centered process really begins. And what happens is the care coordinator or case manager really identifies the need and what steps are required to comprehensively care for the member. So this can be anything from just helping the member find the right dentist who can provide care based on their need, all the way to creating a plan of care that involves connecting with caseworkers, caregivers, other medical providers, mental health providers, and community resources to ensure that the whole member is cared for. And then the last step is around improving health outcomes. So making sure that the member has received all the support and education that they require to have an ongoing source of the care appropriate to their needs. So I spoke about the graduation rate on the previous slide. And again, that graduation means that the member or the caregiver is able to manage their own dental care moving forward. Next slide, please. All right, so this is an actual case where case management was provided to an adult IDD member who struggled to find a provider willing to treat their needs. So DentaQuest sent a health risk assessment as a part of their member outreach. The caregiver completed it and mailed it back. She received a follow-up call from an outreach coordinator who was able to identify a qualified provider who could treat the member. So again, this is an example of an adult IDD member. They needed access, or they needed help with access to care, and this is what was done to provide that access to care. Next slide, please. Here's another recent example that shows how we were able to connect individuals with special healthcare needs to timely care. So these 4 individuals were already in the case management and care coordination program, but the barrier in this instance was OR facility time, which we know is extremely, extremely scarce for dental-related procedures. DentaQuest's director of case management reached out to me and asked if I could assist with contacting executive leadership at Haymarket Hospital. So I was able to connect with the director of perioperative services, and we set these 4 members up to be seen in the OR at Haymarket Hospital. So this goes back to the collaboration between the benefits administrator, the State Department, and the MCOs to ensure that the member is being taken care of. Next slide, please. All right. This is information that we provide to our relevant stakeholders, other health professionals, and community partners regarding the program. Again, referrals can be sent from the member, the caregiver directly, a responsible party, anyone inside the member's care team, a physician, a social worker, nurse, caseworker, other dental provider, MCO. There's really no restriction on who can send a referral to case management. If a member has a significant barrier to getting the dental care they need, i.e. a disabling condition, socioeconomic status, medical complexity, this is the program in Virginia. Next slide, please. All right, this is the case management referral form. So this form needs to be copied and pasted into an email and sent securely to the email on the previous slide. Individuals who are submitting referrals are instructed to complete the form to the best of their knowledge and add as much information as they feel the case management team needs to know. There's really no limit on the amount of information that can be added to this form. I did highlight and want to flag the fact that there's a specific question about special needs or medical conditions that the member has as well. Next slide, please. This is a form with some pertinent information that needs to be included, almost like a cheat sheet, if you will. Again, I've highlighted where we ask for any specific chronic medical conditions as well. Next slide, please. This is a de-identified example of a referral. Next slide. All right. So this is the same example with some verbiage at the top. So this is to show that we encourage the referrals to be as descriptive as possible and really not limit the description to what's on the template. So as you can see here, there's a mention of the member having hypertensive heart disease and autism. So once the referral is submitted, the referral comes into the case management team, and the member or caregiver can expect a call from a dental case manager within 48 hours to begin the care coordination and case management process. The case manager will provide an additional assessment of member needs, and then we'll begin to put a plan of action together to assess and address the member's need. I mentioned it earlier, but I also just want to reiterate again that from this point, there will be a one-on-one personalized communication between the member and the caregiver with regard to case management. Next slide, please. I think that may be Yeah. So we've covered a lot of information in a short period of time. I really want to be respectful of Mary and Dr. Belaski because they have a lot of great information to share with you as well. Dr. Harrison and I are always amenable to connecting with individuals within the health space to discuss ways in which we can help to improve oral health, not only in Virginia, but really nationwide. So we're more than willing to set up some time to discuss further uh, with respect to oral health and the role that it plays on chronic disease. I've left our contact information. Please write it down and use it. We are a resource here. We really consider it a privilege to share our experiences with those of you on the call. So with that being said, I will pass it back over to Maddie for, I believe, a presentation from South Carolina.
Yeah, thanks. Thank you so much, Justin's really fantastic information. We're going to be moving to Dr. Blasky in just a second, but there was a specific question in the chat. Curious about the 77% engagement rate for care management in Virginia. What strategies do you use to get up-to-date and accurate demographic information for Medicaid members for a successful contact? I suspect you might have covered all that in the information on the referral process, but just seeing if you had anything to add to that information that you presented.
Yeah, so that 77%, I don't know if you want to go back to the slide, but that 77% graduation rate is it's organization wide for DentaQuest. So within DentaQuest, not only in Virginia, but they have a 77% graduation rate of members that graduate from the case management and care coordination program. So it wasn't specific to the graduation rate in Virginia. And honestly, this program began in 2023, so it's a rather new program. So we're in our infancy stages of data collection. So I hope that answered the question. If not, I don't know who asked the question, but I'm happy to chat further offline if necessary.
Okay, awesome, perfect. Well, thanks so much. And at this point, we will move on to Dr. Blasky in Connecticut, who's done some really exciting work around medical dental integration and outreach for people in the Medicaid program with diabetes. So I'll turn it over to Donna. And you'll just have to come off mute. We still got you on mute. Sorry, Donna.
Okay, can you hear me now?
Yes.
Okay, I'm sorry about that. Please allow me to apologize to you. I had a medical event this weekend and I pretty much lost my usable vision this weekend, so I'm kind of winging it from the top. I want to let you know, I have done this project for about 15 years, which is why we chose EDUs to present to you, and it became cross-used against all other disease states with the same type of methodology. So first thing I wanted to tell you is we work with Benecare, and it's just me at DSS to help out with all this. And together we make up the Connecticut Health Partnership. We have been a terrific working team for about 15 years. In 2008 is when the Connecticut Dental Health Partnership was established. We knew back then that medical dental integration was important. Could we move on to slide 3, please? Slide 3 is where we say our body it does not function in silos and our teeth are not accessories to our body. Slide 4, please. Okay, what we did is we looked at the total ED visits that we had in the Medicaid population. We did this work starting in 2011. So 2008, 2009, and 2010 was when we still had managed care overseeing our medical. So we had, multiple medical care, managed care agencies submitting data. So it isn't quite as clean as data that we had later on when we became a carve-out and an ASO structure. We did a very deep dive into the data, and when we saw that, we saw an incredible amount of high ED use, and we know that's not anything new to anybody. We have a lot of ED users because people don't understand or know the importance of good oral health. And when we did this deep dive, we also looked at other ancillary costs related to it, which is very important when you're presenting your information to the policymakers. You can't just look how much it costs to go to the ED. What you have to look at is what are the associated pharmacy claims? Those can add up quite quickly. The ED use, had they seen any practitioners, and the practitioners might have sent them to the ED. Also, you have to look at other claims such as non-emergency medical transportation. For states of you who provide that, that can be quite costly, especially when you have people use an ambulance to get to the ED. In 2009, 10, 11, 12, it was very common for people to use the ambulance to get to the ED because it didn't cost anything. So what we did is we started looking at the cost of what it was, and we found it was roughly 9 million or 900,000, but really give or take 100,000 a year, all the way up and until 2015, 2016. If you can go down to slide 10, please. This is the number of people that we saw who visited the ED for just one visit. When we went back and analyzed the data, we found that there was a lot of common themes that occurred that we've all heard. People not thinking oral health is important, not knowing, that they had dental benefits, lack of providers when we had more than ample providers. So next slide, please. These were our 2 to 3 ED visit users. Next slide, please. The next one was 4 to 6 ED users, and this is all in the same year. The next slide shows how many 7 to 9 ED visit users we had. And then slide 14 shows more than 10 ED visits. If you see the little blue ribbon, our personal best was 76 ED visits by one person. But this was during when opioid crisis was increasing. There was not a lot of work being done around it, just starting to happen. And he was drug seeking, and his ambulance costs associated going to the ED were quite costly for us. Okay, 2015, I'm sorry, slide 15, please, shows the costs. In 2017, we started seeing our return in investment. We started seeing a decline. And I'm very happy to report it took a lot to make change happen, but it was worth the investment because now we have more than double our population, yet our ED costs and associated costs are on the average of about 500,000 a year with 1.1 million clients, where before we were at 1 million and peaked at 1.7 million. Slide 18, please. And these are some pictures of some things that we used to address ED problems that we had. A lot of the EDs were not familiar with the Connecticut Dental Health Partnership. They didn't know that we had providers and were a resource. So we gave them prescription pads, which in those days were still being used, made a great hit. They give this to the client and say, call the CTDHP and make an appointment. And we had posters up in the ED, and we had them go to every ED. We had meetings with the ed directors, and we also had our community outreach workers, our community health workers go to each ED and train the staff and replenish the materials. Slide 19, please. Okay, this is our hypothesis model, and this developed out of our experimentation of how to best approach our problem ED users. What we did is we formulated a hypothesis, we designed a solution, and then what we do is we test the solution and we adjust changes as needed. We just don't keep doing the same thing by the same thing, over and over and expecting a different result. I think Albert Einstein said that was a big mistake to do. And Benicare first presented this at a CMS meeting nationally, and then I later presented it at another CMS meeting in 2012 with MISTA. Okay, slide 20, please. Okay, how did we do this? We merged our claims cycles that we looked at with our utilization data and tried to get them to sync up by the time we got the ED use and the claims from the hospitals, which sometimes could be 2 weeks later, 3 weeks later, a month later, just an incredible, enormous amount of lag time. And then what we did is we crosswalked the people that we had who were in the ED use against their dental claims and then attempted to outreach to them. And we did outreach by a couple of different metrics. First, we started automated phone calls, And our return phone call rate was not the most ideal. And then we added second and third tiers to reach people. The second tier was actually mailing a letter to people, and we know how well that works. We all get a lot of mail back because clients don't keep up their addresses. And then we'd have a personalized phone call go out by what we called it our dental health care specialists, but now are called our oral health navigators. And we had some success rate with that, but it was still not where we wanted it to be. Slide 21. We had to measure our outcomes, like I said, and initially we had a 2% return of our calls. And then on slide 22, we focused on more critical diagnoses and reached out to people there. And we had an 8% success rate with that. But you know what? That still isn't very good. And we had a big lag time. So in 1923, I'm sorry, slide 23, please. We modernized our processes and outcomes. And what did we do? Well, we automated our calls into our CRM system. And what we also did is we integrated into our Connecticut State HIE, which is known as Connie. So we're getting real-time data. It reduced our lag time, and guess what? Here's where the benefit was. We are now getting up-to-date demographic information on clients and could reach them. So our lag time went from months being able to reach people to literally down to days. Okay, slide 24, please. We saw that we still didn't have the most ideal return rate. So what we focused on were critical diagnoses, the more severe ones where, people needed immediate attention. And then we also looked at people who had multiple visits within a 30-day period. Despite, all of our education efforts and our good network, we still have people who like to go to the ED for whatever reason for their oral health conditions. So when we switched, to our HIE system and doing that, we have now an 86% success rate of reaching people, and we had a 13% successful closure rate on getting people into oral health care, within a dentist's office within 120 days. Slide 25. Okay, we looked at our dental claims and then we crosswalked who was a utilizer and non-utilizer and further stratified things that way and looked at that. And when we did that, we had a 34% we had a 34% success rate with our closing our clients and having 120 days of getting into a dental home for oral health care. Slide 27. My whole point of the presentation is you need to look at things as an interrelated system. So you can't just isolate oral health and look at oral health. You have to look at everything that's associated with providing good oral health and the condition. So if you have diabetes, end-stage renal disease, any one of the, conditions that Justin or Dr. Harrison mentioned, you could do the same methodology we did here, except using ED data, use disease state data by using their diagnosis codes. And that's readily available in your medical claims data. And when you add that with pharmacy, transportation, physician visits, it really adds up to a cost. Okay, you want to make sure that you have a good hypothesis and a good outcome measure to show that what you're doing is really beneficial and that you're having a good outcome or a positive outcome. Next slide, please. And then what were our goals? Our goals were to reduce the ED use, which we managed to do. The second thing was to get people with comorbid conditions into, regular routine care to reduce the cost of, their chronic condition management and to reduce the overall cost to the program and unnecessary ED use. And I think that's everything I needed to cover. And I'm happy to take message. And again, I apologize for being a little disjointed on this.
No, that was fantastic, Dr. Blasky. Thank you so much. Lots more to talk about here, so we'll look forward to questions in just a minute. But first, I want to turn to Mary Kenyon Jones to talk about the work in South Carolina related to some of their chronic disease pilot projects, and also just the work they've done at a state level to build momentum and coalitions around this topic. Mary
Great.
Kenyon?
Yes, thanks, Katie. It's great to follow such wonderful presentations. I've been taking notes, as I'm sure all of y'all have as well. I serve kind of a dual role in the fact that I am with our a consultant to our Department of Public Health in the section of oral health, as well as our South Carolina Oral Health Action Network. So when I'm talking today, is going to kind of show you how these two entities to work together. Really appreciate the opportunity to share information about how South Carolina is trying to break down silos and strengthen networks to support the integration and inclusion of oral health as a part of overall health and well-being. I'm going to share some information about our most recent project, medical dental integration, that focused specifically around oral health and diabetes. We came into this opportunity with some experience around medical dental integration, but primarily related to perinatal and infant oral health. And specifically around patient education, fluoride varnish application in pediatric settings. So this project was our first one that dealt with integration into chronic disease, but we welcome the opportunity to expand our expertise and our network partners. Next slide. These are just a couple of things that we're going to hit on today in the short time I have with you. Talking has already been touched on a little bit, but the bidirectional connection between diabetes and oral health, South Carolina's approach to engage providers, patients, and communities, and then how we're going to move forward, building on project success and maintaining momentum. Next slide. So some initial stats that we considered as we entered the work and began having those internal conversations that we needed to have within our Department of Public Health, specifically like with our section of diabetes and health disease management, began raising questions. Did you know that poor oral health is considered the sixth complication of diabetes? Started to shed light on the bidirectional connection, knowing and say, hey, if someone has diabetes, their risk of developing gum disease increases. In addition, if a patient has diabetes and also has gum disease, it could negatively impact their diabetes, including blood sugar levels. This started the conversation. Next slide. Diabetes in South Carolina is a significant issue. 13.8% of adults 20 years or older have been diagnosed with diabetes. In comparison to other states, South Carolina ranks above the national median. The good news is that when unmet oral health needs are met, it helps improve diabetes results, such as blood sugar levels, and it helps improve a patient's overall health. The challenge, however, is that 44 out of South Carolina's 46 counties have a shortage of dental providers. This, of course, raises the importance of having these discussions in medical settings as well as dental ones and breaking down those silos. Next slide. A good part and a good positive step happened for us when we were able to receive one of 5 states to receive CDC funding to address oral health and chronic disease. We chose to focus specifically around diabetes because it being such a significant need in our state. And so our medical dental integration effort was launched in 2018. Next slide. So our team sought to address the oral health needs of patients with diabetes by building a statewide system to provide the internal and external education and outreach to support the integration of oral health and chronic disease services. We also wanted to strengthen community clinical linkages by including diabetes screenings for dental patients and dental screenings for patients with diabetes. We utilized the pre-diabetes diabetes screening tool endorsed by the CDC for use in dental settings, and we, in consultation with our dental consultant, developed a brief oral health assessment tool for use within medical settings. We also encouraged patients with diabetes to share their health status with their dental providers and share their oral health issues with their medical provider in an effort to break down the silos that exist between medical and dental providers. In beginning this work, we also found that some silos existed within the health department itself between chronic disease program areas such as diabetes and heart disease and oral health. So some internal work needed to be done so to help the agency raise the importance and visibility of oral health as an impactful part of overall health. Next slide. South Carolina, we're kind of a small state, but we are divided into 4 public health regions: Upstate, Midlands, PD, and the Low Country. And even though we are relatively small, each of these regions are unique and diverse and have their own set of health challenges and barriers to care. Raising awareness about the connection between oral health and diabetes with the public was an important first step for the project. We approached the project with a decentralized focus. This was done by equipping and collaborating with our regional staff members to expand our reach across the 4 public health regions of the state. This took place internally by training regional teams that included community engagement directors, health educators, and community health workers. We asked them to include information about the connection between oral health and diabetes within their staff meetings, starting there. They were also equipped to engage with external stakeholders, including providers, as well as community-based programs that connected directly with patients with diabetes who lived within their communities. In order to measure the strength and the scope of the oral health diabetes statewide network, we worked with a network analyst who conducted 3 surveys over the life of the project. The survey results show that the connections with relevant organizations increased from 69 to 110, with the number of undirected connections increasing from 176 to 374. These 2 diagrams show the change between the first and the last survey, and you can clearly see the increasing engagement, expansion, and complexity of the network. The network survey also showed that there was a decrease in centralization. So in other words, all the activities weren't just happening at the central location of the health department. And that there was, even through DPH played an important role in expanding the network, there was a noticeable regionalization of the network as the regions expanded their connectivity. And that was one of our key goals of the project, so that those regional staff could connect with their local partners. Next slide. Another important element of our project was our collaboration with a strong evaluation team who collected quantitative data by setting up tracking logs for regional staff, pictured here, collected qualitative data by conducting focus groups with the oral health team and the MDI leadership team and the pilot site staff. This qualitative data gave us more insight into the elements of the project that were working, as well as the approaches that needed to be tweaked for a larger impact. We were also, probably one of the biggest successes of the project was locating those oral health champions that are so important at the regional level, who engage directly with patients with diabetes to help educate them, raise awareness about the impact of diabetes on their oral health, as well as the impact of oral health on their blood sugar levels. The lack of patient awareness around this topic was very surprising. Those regional champions were passionate about their work. They found unique opportunities in traditional and non-traditional settings to connect with people who needed to hear these messages. Pictured here are 2 examples of the outreach, or the type of outreach that took place. Some simple healthcare, a health fair event with community focus, but then also some smaller classroom activities took place that utilized PowerPoint presentations to directly educate patients about the impact and the connection. Next slide. One of our most significant parts of the project was our MDI leadership team. These members were selected based on their expertise, their experience, of course, their availability and willingness to participate. We met with this team on a quarterly basis throughout the project period and utilized them to identify and maximize our project resources. They had a work plan that guided their work. They helped us pick the key messages that needed to be shared, and they really helped connect us to some additional opportunities to spread and get the message out around the connection, the bidirectional connection between oral health and diabetes. This group opened up our doors for the team to present at state conferences, be published in association periodicals, and connected us with support groups that directly impacted patients with diabetes. And those are some of the organizations that were represented on our team. Next slide. To support our outreach efforts across the 4 public health regions and within the agency, one of the key things that we had to do was to develop a medical dental integration toolkit. In the beginning of the project, we decided to co-brand our materials with an existing organization that was already out there doing some work around diabetes called the Diabetes Action Council. We did that so that our resources would be embedded with existing outreach for patients. Our regional teams took these resources and added tools such as toothbrushes, toothpaste, and floss to create what they named Smile Kits, and they used these kits to get their foot in the door with providers and clinics. Next slide. Initially, a bigger part of the project was to test and do some pilot testing, but we had this project during COVID. And so that derailed those efforts a bit. But once things did settle down, we were able to do 2 small pilot testing to test patient messaging, screening tools, and referral forms. And here's a quick glance of the results that came from an FQHC named New Horizon, located in the upstate of South Carolina. Next slide. Unfortunately, all good things must come to an end. So the CDC funding that funded this project ended in August of 2024. However, the South Carolina team was able to apply and receive the next CDC grant. This new grant began in September of 2024 and is supposed to be a 3-year opportunity. This funding will allow us to build off of and expand what worked well with the 1810 project, such as the MDI leadership team of experts and champions, the regional model, outreach model, that will also allow us to expand and strengthen this work with a greater focus on the analysis and dissemination of oral health diabetes data. We will also work more closely with our Oral Health Action Network and help identify potential areas for policy change, and the data will help support this case. Go to the next slide, and I'm just going to go quickly through that. That's our Oral Health Action Network. And go to the next slide. The network is organized across 4 action hubs, of which you can see one of them is medical dental integration. And that's where a lot of this work can continue to take place. Go to the last slide, or slide 15. So just some final thoughts. The MDI leadership, or the MDI Oral Health Diabetes Project, was successful in strengthening and expanding the oral health networks in South Carolina. It really helped us synergize our efforts around medical dental integration. We learned a lot of lessons from the pilot testing. We realized that the regional network approach does work, and it can be done and continued at minimal cost. Yet, as we all know, we're living in very uncertain times when it comes to funding. In fact, the funding that's going to support this next opportunity may not even come to its full fruition over the next 3 years. We are not sure of the status of that. With this uncertainty, removing these silos that we're talking about today, strengthening the network, and finding champions who will be more important than ever as we strive to continue this work and reach the most vulnerable in our state. So I'm really glad for the opportunity in this conversation today, because we will have to look at different ways to make this work continue. Last slide has my contact information and just some pictures of the energy that was around this project. It was just a great experience. Please reach out to me with any questions or any thoughts or any ideas, and I would love to have a chance to engage with you. And that's it.
Yeah, that's wonderful. Thank you so much. And I think that's a great note to end on, in terms of just the need to all be working together and also be thinking about some of the return on investment in ways that we can be working more efficiently given the uncertainty ahead. I know there were 2 specific questions in the chat about the presentation, so I want to get to those. This one is for Mary Kenyon. Were all the dental patients screened for diabetes, or only patients with diabetes risk factors?
The patients with diabetes risk factors are the ones that were screened. Yes.
Awesome, thanks. And then Dr. Blasky, there were some on your presentation. Is the ED data for adults and children? And just noting that 120 days to find a dental home is still a little bit long. Are you taking any steps to reduce that, or is there a sort of decision tree on patients that might be prioritized? And we'll just need you to come off mute.
Okay, can you hear me now?
Yes.
Okay, I'm sorry. The original data, it includes children and adults. What we do is we stratify them down later on, and I didn't break it out because it would just be too much to present into the children groups and adult groups, and looked at what their actual needs were. I'm sorry about that. Okay, can you hear me now?
Yes.
Okay. What had happened was we had to break them down into utilizers, non-utilizers, and then stratified them, for disease severity. And now that we can do that, it works better. 120 days, yes, is great, but trying to get people to comply is the more difficult part. And that's where we find most of our resistance at this point. We can get them into appointments. We can get them into emergency appointments within 24 hours, 48 hours for, urgent. And our standard is up to 8 weeks for routine preventative care. If they have, something that needs to be seen by an oral surgeon, an endodontist, we really, are going after them, and that's what we consider more severe and periapical abscesses. Other things like trauma, where they can be taken care of in the ED or go to an oral surgeon, we make sure that they do get into the right types of care that they do need.
Got it. Thank you. And maybe that actually segues well into another question we got early on, which I think was specifically spurred by Dr. Hairston's presentation, but there was a question about whether there were recommendations or best practices specifically related to working with seniors, like the idea of having simpler, more frequent cleanings. But I know you all are doing work with specific patient populations that might have cognitive or physical disabilities. So
Right.
if you'd like to expand on ways that you're addressing some of those barriers that patients with special needs face as well. But I'll ask Dr. Hairston to jump in with the seniors.
Yeah, I'll allow Justin with special needs, but tell me what your question for seniors had to do with again.
Recommendations or best practices related to working with seniors and connecting them to dental care.
No,
Or
I'll
for instance, having simpler or more frequent cleanings.
yeah, Justin, can you speak to that? Are you still on?
Yeah, hey Doc. Yeah, so I can. I think what we've done is we've really structured our program, and Dr. Harrison spoke on this earlier, ensuring that our seniors are able to have those 3 cleanings a year. Dr. Harrison also mentioned that seniors want simple. Letting our providers or educating our providers and letting them know that hey, we have the preventative benefits here to use, utilize those preventative benefits to get in front of some of the issues that the seniors will have, as they age. So I think we've really harped on the benefit and design specifically on preventive services, just to ensure that again, seniors have those 3 cleanings a year, and strong perio services available to them as needed. So that's a little bit about the seniors, and then with the IDD population, it's just strengthening. What we've done is just strengthen our partnerships with sister organizations. So we work very closely with DBHDS, and I believe they're actually on this call as well, to ensure that members are being taken care of. So if I had to give a recommendation there, it'd be to strengthen your partnerships with your sister organizations. We do great work with Virginia Health Catalyst, Sarah Holland and her team. So making sure that you're partnering with relevant stakeholders that have the similar goals in mind. And that's probably the best that I would say right now.
Great. All right. Well, we are at 3:30 and I don't want to keep people any later. This has been a really fantastic conversation. I think there's lots more that we could talk about. So please do feel free to reach out to us. We'd love to continue this conversation. Just a few other notes that this presentation will be available on NASHB's website. If you'd like to revisit or share with anyone, Megan had just put a link in the chat to do an evaluation. And most importantly, thank you for everybody for coming today, and especially our speakers for this fantastic info. So please don't hesitate to reach out if we can be helpful, and we'll look forward to lots more on this issue in the future. Thanks so much.